We will move to the next speaker, Dr. Yasser Bawaziri, well-known rheumatology and internal medicine consultant, associate professor of internal medicine, also head of rheumatology division at King Abdulaziz University. Dr. Yasser, you are welcome.
Bismillah ar-Rahman ar-Rahim. I'd like to thank you for this nice introduction. I would like also to thank the Saudi Society for giving me this opportunity today to present about malignancy and rheumatological diseases. Okay. This is my disclosure, and these are the objectives. I will move over 4 important points. First, we will start with the most common malignancies associated with rheumatological disorders in general. It's very important to understand there is a bidirectional relationship between the rheumatic diseases as well as malignancy. They share chronic inflammation and immune dysregulation. So systemic rheumatic disease could lead to the development of malignancy, and malignancy with the use of chemotherapy, radiation therapy will lead to oncogenic inflammation, and this oncogenic inflammation will lead to the development of systemic rheumatic disease. Now, there are increased risk of malignancies associated with rheumatological diseases in general. On top of the list, we can see dermatomyositis, rheumatoid arthritis, Sjogren syndrome, and the list goes on. First, we'll start with the cancer risk with the rheumatoid arthritis. Actually, it was described since 1980. We will use what we call the standard incidence ratio, which reflect a relationship but not a direct causality. So just only a relationship from the studies. Now, the most common malignancy associated with the rheumatoid arthritis was hematological malignancy in general that include non-Hodgkin lymphoma as well as granular lymphocytic leukemia. Data from the ARTIST trial or ARTIST cohort, that a Swedish cohort, include a large number of patients, revealed that rheumatoid arthritis was associated with increased risk of lymphoma in 10% of the patient. The control of the disease was associated with the lower standard incidence ratio or a lower hazard ratio with the time. If we use, for example, a biological treatment, and we'll discuss this later, biological treatment could be related to certain non-melanomatous skin cancer. But they found in this cohort, the use of biological treatment was actually associated with the lower hazard ratio of cancer with the time. So this represents that as long as you control the disease, the standard incidence ratio or the hazard ratio will go down with the time. What about systemic lupus? Data from the international cohort of cancer in systemic lupus that include around 10,000 patients. They identified around 431 observed cases. The standard incidence ratio with the highest risk of cancer was non-Hodgkin lymphoma, followed by hepatobiliary cancer. The study was reproduced again around 8 years later and included around 16,000 patients, and they identified around 644 patients. Again, the standard incidence ratio was higher for non-Hodgkin lymphoma that reached up to 3.46. And there is increased risk specifically for those who are treated with azathioprine or cyclophosphamide. What about Sjogren syndrome? Primary Sjogren syndrome was associated with cancer risk more than secondary Sjogren syndrome. And top of the list, non-Hodgkin lymphoma as well as mild lymphoma. There are certain risk factors or certain predictors associated with the lymphoma development in a patient with Sjogren syndrome, like positive rheumatoid factor, cryoglobulinemias, and most importantly, a high score or a high disease activity score. Moving now to systemic sclerosis, they found that there is an increased risk of cancer or lung cancer in a patient with systemic sclerosis, and they identify this more for the patient who were smoke. So smoker patient associated with 7 times increased risk of lung cancer. Also, there are reported cases about esophageal cancer as well. Myopathies in general. Dermatomyositis was associated with the highest standard incidence ratio of cancer. of all rheumatic disorders. Polymyositis was associated with 2.4 standard incidence ratio, and these are data from Australian study that include around 600 patients with the biopsy-proven inflammatory myopathy. They found that dermatomyositis, again, associated with the highest incidence or standard incidence ratio. And they found as the standard incidence ratio will go down with the longer duration of the disease. So i.e., the risk of the cancer will drop as the disease extend for a long time or longer duration. They found that also the pathology of cancer itself was different at the time of diagnosis and after the diagnosis. For example, if you look, for example, to dermatomyositis, we can see that there is a risk of bladder cancer, breast cancer, before the time of malignancy, but after, or before the dermatomyositis, but after the dermatomyositis, the risk change. It starts to in favor for head and neck cancer as well as lung cancer. This area need to be studied more, actually. Cancer risk in vasculitis, they found that the paraneoplastic vasculitis was approximately reported in around 5% of the cases. Leukocytoclastic vasculitis on top of the list. Hairy Knox-Line-Purpura as well as a polyarthritis nodosa also was associated with hairy cell leukemias. Now moving to the second part, which is the screening of malignancy in a patient with a rheumatological disorder. I found a difficulty in finding a resource or a recommendation for this, and I get this most up-to-date or latest, let's say, cancer screening recommendation from French systematic review. First, we'll go over the general population screening for breast cancer, colorectal cancer from 50 to 74, cervical cancer for sexually active female from the age of 25 to 65, and the skin cancer annual screening. They did adjustment for immunosuppressed patient, those who are immunocompromised patient. For immunocompromised patient, they focus mainly on the cervical cancer and the skin cancer, risk of Kaposi sarcomas, and the highest risk of cervical cancer because of the activation of human papillomavirus. So you have to do it more frequently, up to every 6 months you should do a pap smear, especially with the lower CD4 count. Now, what about the cancer screening in chronic inflammatory rheumatic disorders? Actually, for the breast and the colorectal cancer, it's the same. While the cervical cancer, it depends. If your patient is immunosuppressed, so you have to do it more frequently. But if the patient on immunomodulatory treatment, such as DMARDs, conventional or biological DMARDs, you can do it as normal population. Skin cancer, you have to do it more frequently. Why? Because biological treatment was associated with non-melanomatous skin cancer. Lymphoma. So lymphoma, there is a risk of lymphoma, and we know that. So you have to do the workup based on the clinical presentation. I found this interesting question. Should all patients with dermatomyositis undergo screening for malignancy? Actually, these data from systematic meta-analysis, and they found from 2 meta-analyses, they identify around 11 types of tumor, as you can see. And they found a certain clinical predictors for dermatomyositis that include a certain clinical criteria and immunological or laboratory criteria. So the clinical criteria, younger age, more ulcerative changes, Scholl sign, or laboratory investigation if you find a patient with the high inflammatory markers or anti-TIF gamma positivity or NXP2, you should predict cancer or should look for cancer. It's very important to understand only a minority of a patient will develop cancer and patient with dermatomyositis. This represents around 27%. So you have to keep in mind, you have to minimize the malignancy overdiagnosis in a patient with dermatomyositis. You should identify the prevalence of false positive study of malignancy, assess the morbidity and mortality associated with cancer screening, and calculate the cost effectiveness. So in order to do all of this, you have to create a certain guidelines for screening of the patient with dermatomyositis and in general rheumatic disorders. And actually, we don't have it. So we're still following the US task forces as well as the ACP guidelines for the screening. Moving to the third part now, which is the rheumatological manifestation in patients with malignancy in general. It's a long list. I will go over some. Hypertrophic osteoarthropathy associated with the periosteal reaction as well as clubbing, lung cancer. Paraneoplastic polyarthritis, it's unusually presented more in males. It's resistant to corticosteroids. Usually at the age of 52, adenocarcinomas was described. And some of the patients, they were positive CCP and rheumatoid factor, and you can see these are data from several studies. Palmar fasciitis with the polyarthritis syndrome, again, could be associated with ovarian adenocarcinoma with the thickening of the palms, and it's similar to the Dupuytren contracture. It's very difficult to treat and resistant to corticosteroids. RS3P. Again, this is one of the paraneoplastic manifestation, highly responsive to corticosteroids. If you have a patient who did not respond to corticosteroid, think about hematological malignancy as association. Multicentric reticular histiocytosis associated with a granulomatous non-Langerhans cell histiocytosis. A patient usually presents with a coral-like appearance rash, as you can see. This patient, for example, here with the mediastinal mass on biopsy, we can see that the foamy macrophage distribution in the slide. Erythromelalgia can be associated with the lymphoproliferative disorder. Some of the patients could present with a similar problem like a burning sensation. Treatment is aspirin. Sweet syndrome with the neutrophilic dermatosis, again, could be presented with the patient with the hematological or even solid tumors. Tumor-induced osteomalacia, secondary to phosphate metabolism-related disorder. This will lead to increased risk of fractures. Proximal myopathy, again, it can be associated with several types of tumors. And the key is hypophosphatemia in those patients. A resistant type polymyalgia rheumatica that usually happen at younger age, resistant to corticosteroid, more prominent constitutional symptoms. Think about polymyalgia rheumatica-like syndrome. So the clinical clue, if you have a sudden onset of polyarthritis, RA with a monoclonal gammopathy, Sjogren syndrome with a globin albumin dissociation, HOA dermatomyositis, PMR resistant to corticosteroid, eosinophilic fasciitis resistant to steroid, a longer or long-lasting erythema nodosum, new onset rhinoid phenomena, or cutaneous leukocytoclastic vasculitis in a patient who is 50. Now, the last part about the management of rheumatological disease in cancer patient, I try to summarize like the medication together. NSAID and glucocorticoids, there is no strong association with cancer. Methotrexate was associated with the highest or high risk of lymphomas, non-melanomatous skin cancer, to a lesser extent other types of DMARD. Mycophenolate, there is no risk of cancer, and it actually has an anti-tumor effect. Azathioprine was associated with the lymphoma, especially in RA cohorts. Azathioprine was associated again with the risk of lymphomas. Low-dose cyclosporin, conflicting data. Cyclophosphamide, we know that it's a carcinogenic medication. TNF, tocilizumab, abatacept, data consistent about non-melanomatous skin cancer, and we'll go over it in the next slides. Rituximab, actually it's implemented in the guidelines as a treatment for a patient with the lymphoproliferative malignancy. Now, again, back to the ARCHES trial that included around 33,000 patients on biological treatment, anti-TNF, and you can see here the hazard ratio. Compared to general population, you can see the hazard ratio is almost the same in all biological treatment, including abatacept, tocilizumab, but there is a slight increase in a patient who are treated with abatacept compared with the general population as well as other types of biological treatment. So there is a slight increase. So data after like a post-marketing data that include 10 years data from 4 different cohorts, they found there is no difference regarding abatacept in overall malignancy, but they found only increased risk of lymphoma, and they found this from the ARTIS cohort. What about the transthyretic DMARD? Data from 2 meta-analyses, there is no increased risk of cancer, but as we know, the oral surveillance study in a patient who was selected above 50 with at least 1 cardiovascular risk factor, some of them are smokers, there is a slight increased risk of non-small cell lung cancer compared to anti-TNF, and they found this in the 2 doses of tofacitinib. And as you can see in the Kaplan-Meier chart here, you can see that the separation at the hazard ratio was at around 2 years of continuous use of the medication. So this would raise a question. Does it relate to the longer duration of treatment? Again, data from the ARTIS cohort, the Swedish cohort, they try to look for the association or risk of cancer comparing JAK kinase to other anti-TNF, and the JAK kinase here included tofacitinib and baricitinib, and they found that the overall risk of cancer was similar to anti-TNF. But there is a slight increased risk of non-melanomatous skin cancer, and this was the first report. And they found that this association was after 2 years of continuous use. So maybe the continuous or longer duration of use of JAK kinase inhibitor could be related to underlying cancer. MSK-associated chemotherapy-related problem like gemcitabine. You can see rhinoid phenomena, scleroderma-like presentation. So you should keep this also in your mind. So finally, we'll go over a small case or a simple case. A 65-year-old male patient referred from oncology department. He is currently on nivolumab, which is one of the monoclonal antibody for the treatment of cancer. You should keep in mind immune checkpoint inhibitor-related complication. And these complications, including inflammatory arthritis, polymyalgia rheumatica, myositis, and in some cases also Sjogren syndrome. Now, it has several mechanisms of action, but we know that these monoclonal antibody will bind to the programmed death receptor and result in degradation or tumor cell death. Several mechanisms of action. We have at least 25 types with use of several types of cancer. How you are going to approach this patient, you have to know that is this complication or this problem happened after the use of immune checkpoint inhibitor. So is it musculoskeletal problem, or is it like articular problem or a muscular problem? If it's a muscular problem, look for the CK. Myositis is there. 50% of the patient could develop carditis, so you have to screen those patients. Or it could be MSK, polymyalgia-like presentation, or inflammatory polyarthritis. How you are going to manage those patients? The management, actually, NSAID and corticosteroids are cornerstone. You should discuss this with the oncologist at your center. Steroid-sparing agent sometimes can be used, but you need to stop the immune checkpoint inhibitor. These are the approaches, how you are going to approach those patients. So inflammatory arthritis, moderate activity, start with the corticosteroids, 4 weeks, no response, stop immune checkpoint inhibitor, go for the next step. Again, for polymyalgia rheumatica, if you have a patient with the polymyalgia rheumatica, treat with the corticosteroid, 4 weeks, no response, increase the dose, no response, add DMARD. Myositis and myalgia, if it's just only a simple myalgia, just use ordinary medication like acetaminophen. But if there is increase in the CK, you have to be careful. You have to screen for carditis. If there is a dysphagia or shortness of breath, you can go with the plasmapheresis, IVIG, and upscale your treatment. What about a pre-existing autoimmune disease in a patient you on or need to be initiated on immune checkpoint inhibitor? You should know the patient must be like on minimal disease activity with the minimal immunosuppressive treatment, i.e. corticosteroid less than 10 milligram. And this was consistent even with the EULAR recommendation. Before the initiation of cancer immunotherapy, there is no evidence of screening for autoimmune disorders before the initiation. So start the treatment, discuss everything with the oncologist. So, and here I have to conclude, ladies and gentlemen, this is my conclusion. We need to know that there is a bidirectional relationship between rheumatic disorders and malignancy, and low disease activity associated with the better control, low disease activity, i.e. better control associated with the lower cancer risk. Breast and colorectal cancer screening is similar to the general population. Closer surveillance for cervical cancer and skin cancer. Cervical cancer, especially if your patient is immunosuppressed. Tumor markers are of a low sensitivity and specificity as a screening for a patient with rheumatic disorders. The majority of DMARDs was not associated with increased risk of cancer. We need more data about the prolonged use of JAK kinase inhibitor and abatacept and the risk of cancer. Treatment of immune checkpoint-related adverse event is guided by the severity of the clinical picture, and you should, again, discuss this and address it with your oncologist. Thank you very much.